So on behalf of the Greater Columbus Spasmodic Dysphonia Support Group, we welcome everyone to this meeting. We have enjoyed having quarterly meetings as a support group since 2007. And I was asked to speak today about reflux because it is something that comes up and it has a great impact on the voice, and especially for people that already have an ongoing voice disorder like spasmodic dysphonia or tremor. I have a few disclaimers. First, I'm a speech pathologist. Many of you know that. We refer to ourselves as voice pathologists when we work exclusively with the ear, nose, throat physicians. I'm not a medical doctor. Speech language pathologists describe the conditions that patients have, but the physicians are the ones that actually diagnose. So medical questions should be directed towards a physician. I will try and answer anything at the end of this talk, but just so you know, I'm not the one that should be giving the diagnosis or medical advice. The goals of the talk today are, and I should say that I wrote these in very big script to try and help Mare out because of her vision problems. But the goals are to describe two different types of reflux, to discuss the impact of reflux on the voice, and to provide some treatment options. So there are two types. The one that you hear more commonly is GERD, which is gastroesophageal reflux disease. And that's when you hear all the commercials on Nexium and all the medications on commercials with the food fighting and indigestion and heartburn. That's usually a GERD condition. And the second kind that we see more commonly in the ear, nose, throat practice that we're in is laryngeal pharyngeal reflux. Laryngeal relating to the larynx, pharyngeal relating to the pharynx or throat. And so that is a type of reflux where symptoms present themselves in the throat. That's the most common kind that we will see in our practice. GERD is really the backflow of stomach contents, and it's primarily acid and pepsin through the lower esophageal sphincter into the esophagus. I'm going to show you a picture here. If you look on the schematic, you can kind of see in the image of the woman where the stomach is oriented. And if you look on the right, you see the stomach, and then above it, that tube is the esophagus. At the very bottom portion of the esophagus is a sphincter that closes like a purse string unless you're eating. And that's called the lower esophageal sphincter. Reflux or GERD is the backflow of stomach contents up through that relaxed or open lower esophageal sphincter and into the esophagus. You can look at this picture here, and again, if you look over at the right, you'll see on the top this cross section that the LES or lower esophageal sphincter is closed, so all the contents in the stomach can't get out. It is closed, it provides a barrier. But in the lower picture where the LES is open, it will allow backflow to occur, and that's just by opening of that sphincter. The most common GERD symptoms, and this doesn't have to be all inclusive, but if you have a couple of these, you probably have GERD going on. The most common would be heartburn, then regurgitation, indigestion, sour stomach, belching, hiccups, swallowing difficulties. People may say, oh, I shouldn't have had those barbecue chicken wings, or I shouldn't have eaten that, that really bothered my stomach. The causes of GERD are many. But you're going to kind of see a pattern here when we start talking about LPR. So overeating, eating too much at one time, think about that after Thanksgiving meal, or obesity, in both cases, just having for the overeating too much food in the stomach that just distends the stomach and may relax that lower esophageal sphincter and allow things to come up. And obesity would be because there's too much pressure on the front of the stomach that could open that LES. Leaning forward or reclining back within 3 hours of eating, it takes 3, if not closer to 4 hours after you finish eating for food to be digested and for the acid levels and other digestive juices to reduce to normal. Then you're safe to recline. If you recline or lean forward prior to that, you can get some regurgitation. If you wear tight clothing, especially around the middle, again, that's very much like obesity. You're just kind of forcing things to backflow north, head north when they should stay south. There are many medications that can upset the stomach and may contribute to reflux. If you've ever been on antibiotics, or if you've had an orthopedic problem, maybe you sprained an ankle or had a shoulder problem and you were put on high doses of Motrin or Aleve for a period of time, that can cause some GERD issues. And then diet, of course, and the most common things that we've heard about for a long time are spicy foods, fried, caffeine, alcohol, chocolate, carbonation, and peppermint is another one too. Smoking is another thing that can cause GERD, and that, very much like carbonation, is the smoking itself will relax the lower esophageal sphincter and again allow things to backflow up. Stress, we're kind of coming around to stress. Early in my career, we really thought stress played a big role in GERD and LPR. And then the gastroenterologists, I really think, got us away from that. They're like, no, it doesn't matter. It's not that big of a deal. And all along, all my experience over decades really now treating patients is that stress does play a major role in our GI system and how things function. And you know that too. You know, if you get constipated or diarrhea when you're really upset about something, it's the same thing can happen in terms of the two types of reflux. Hiatal hernia is a physical change where the stomach is actually herniated up through that lower esophageal sphincter. And so the LES would likely always be open. And if that's the case, then you've just got direct backflow, or, there's a direct port for things to backflow up. And pregnancy kind of has two issues. Early in pregnancy, hormonal changes can cause reflux. And then, of course, later, as that fetus continues to grow, the pressure on the abdomen, can cause some reflux. And then lastly, there's a weak lower esophageal sphincter. Now, GERD is associated with just that lower esophageal sphincter being open. Then we'll go to laryngeal pharyngeal reflux, which is the type we see more often in the ear, nose, throat world. That's also backflow of digestive juices, again, acid and pepsin, back up through the lower esophageal sphincter and the esophagus, but this time it also comes up through a relaxed or open upper esophageal sphincter and can fall into the larynx or pharynx and actually cause some reflux changes. So if you look at this image, the one on the left will kind of give you orientation of the stomach. If we start at the bottom of the stomach and the LES above that, and then the food tube or esophagus. And if you look over at the right, you're going to see that there is an upper esophageal sphincter at the top of the esophagus. If that relaxes open, it can allow things to spill up north, head north into the pharynx, the throat, and the larynx area. LPR symptoms, this would kind of be a classic one, is burning in the throat. We refer to LPR, and it is in a lot of our literature, as silent reflux, because many patients that come in with symptoms, and I'm going to go through what those are, they think that this is not a reflux issue. In fact, if they have no GERD going on, they'll say, I can eat anything. I've got a cast iron stomach. They just can't believe that this problem in their throat could be due to something going on in their stomach. Extraesophageal reflux, also another term for LPR, refers to the extra is outside of the esophagus. So it's reflux that occurs outside of the esophagus. The symptoms of LPR, when somebody comes in, they may say they have a lot of throat clearing or coughing. They may have a sensation of a lot of secretions in the throat, or maybe even postnasal drainage. They may have an acid taste or just a different taste in the mouth that doesn't taste like food that they've had. They also, though, could have regurgitation of food that they ate earlier, and they can retaste that. I always tell patients that it's fine to have that taste as it's going down, but you don't want to revisit it unless it's on eating seconds. You don't need the regurgitation. There can also be nighttime choking. Some of our patients will wake up in the night with a reflux event, and it causes some choking, or they feel like they can't breathe at night. Hoarseness can be an issue because if acid slips in to the larynx, it can change your voice. And patients that come in and say, I'm hoarse in the morning, or I've got kind of a heaviness, or my pitch is lower, those can be voice changes. And then changes in your swallowing, where you feel like there's a lump in the throat or food catches as it's going down. Globus, this is another very common symptom of LPR and is one of the hallmarks that's almost exclusively related to laryngeal pharyngeal reflux, unless you actually have a growth in the throat area. And that's patients will complain about having a lump in the throat sensation. Shortness of breath, usually on inhalation, that can be an issue, especially for people when they're exercising. It can agitate the stomach contents, and if that comes up and spills into the larynx, the vocal folds want to close to protect the airway, and then someone feels that they're short of breath. And then, of course, throat burning or sore throat. There's the acid that can come up into the throat. And you may have noticed that I didn't title this acid reflux because it's not just acid that can come up, it can be this pepsin, which is an enzyme. Causes of LPR are the same as Gerd, and we went through those before. So what causes one can also cause the other. It just depends on whether that upper esophageal sphincter relaxes open. Now, interestingly, having some regurgitation of acid or stomach contents into the esophagus is a normal condition. I've read that you can have anywhere from 40 to 72 episodes of acid backflowing into the esophagus, but you get to a critical point where the acid now will start eating away at the lining of the esophagus. And that's when you will start having heartburn or some of those other symptoms. LPR, on the other hand, there is no protection in the larynx or pharynx for acid. One episode can start causing an inflammatory response. So this is why some of our patients that might have intermittent reflux changes may have the LPR symptoms, but they don't have the Gerd because they haven't hit that threshold for Gerd exposure, of acid exposure. So when someone comes in, and we're evaluating LPR, the speech-language pathologist and the ear, nose, throat physician. In our practice, they will usually see the speech pathologist first. And so the first 6 are things that I can offer to work up the reflux. The first thing I would do is ask patient history and symptoms, and then I would go through an index, and all these things I'm going to go through individually with you. After we see the patient, we would kind of present the whole case to the physician, show the pictures, tell them how they did on all these other things that we had talked about, which are mainly 1 through 3, what we would do. And if I suspect there's reflux, then I'll go to number 6 and I'll start talking about some reflux reduction strategies. The patient then sees a physician. If they agree, they may want to recommend a medication trial. My husband and I are getting more accustomed now to not starting with reflux medication, but doing some of the other measures that I'm going to talk about today. And I will relate to you why we don't do that. And then for a physician, may go ahead and order a barium swallow study, which is an esophagram, an x-ray study of the esophagus, or refer the patient to a GI doctor if certain symptoms present at our visit. So patient history and symptoms, I would ask them, what brought you here today? When did the symptoms start? Depending on what they tell me, I may ask them, did you have any changes in your health? Did you start any new medication? Did you have any lifestyle changes prior to the symptoms developing? Sometimes they'll say, you know, it's crazy. I just started a running program and all of a sudden I'm having all these issues. Well, it could be reflux that's, you know, making that situation worse. And then, you know, what have you tried? I always ask, what have you tried to manage the symptoms? Have you tried any medications or any other strategies on your own? Because sometimes that will help in diagnosing what the issue is. So this is just one example of a case history of a patient. 57-year-old male complains of chronic throat clearing, phlegm, a lump in the throat sensation. In talking to him, the symptoms started about 3 months earlier when he was taking high doses of an anti-inflammatory medication for knee pain. So the patient had throat clearing, phlegm, and thought that maybe it was allergy. So but the patient I said, did you try anything? The patient says, I had no response to 2 weeks on an allergy medication. As you'll see, when I showed you some of those LPR symptoms, throat clearing, phlegm, yeah, they could sound like allergies. They could sound like other things, which is why we consider this a silent reflux. They're just kind of these vague symptoms that involve the throat, but beyond that, there are lots of, different variables that could relate to other conditions. This is the second thing that I will do if I'm suspecting that this patient has reflux. And my colleagues actually hand the patients a piece of paper and have them fill it out, but I don't do that because I don't want them to see that I'm asking them about reflux. So especially if they're a little resistant, I can tell that they don't think that this is a reflux problem. So I will say, okay, I'm going to ask you I'm going to make a statement and you're going to give me a number 0 to 5 based on how true that statement is for you. 0, it's never a problem. 5, it's a problem all the time. So sometimes might be 2 to 3. You just pick a number and then I go through each one. Hoarseness or problem with your voice, clearing your throat, having excessive throat mucus or postnasal drainage, difficulty swallowing, coughing, breathing difficulties, choking episodes, lump in the throat, and then, heartburn, chest pain. And then I'll add up the numbers. And if their total exceeds 13, they probably have reflux. So I kind of wait to share that with them once I have a full picture. The next thing I do is a laryngeal exam, either through the nose or the mouth. The physicians may do this too, depending on if the patient also presents with hoarseness as one of their complaints. I'm going to do a little more detailed of an exam. I've got more sophisticated equipment than what our physicians have. But just to orient you, just to look at this larynx here, and those of you that have seen me in my office might be familiar with this, but the white V are the vocal folds, and they're in an open or abducted position. The person is just breathing right now. There are no growths on the vocal folds. Those edges are nice and clean and even. The front part, which is on the bottom of your screen, is the anterior commissure. And that would be right behind your Adam's apple, right behind here. And we're looking down on the person. So the vocal folds aren't up in the neck, they're actually down. And the posterior commissure is back, would be, the most posterior part of the vocal folds where they actually open apart. So when I'm looking down on a patient through their mouth or nose, this is the angle that I'm seeing. Where you see the words normal larynx is right about where the esophagus is. So it's very close to the larynx. And we know that we've all had the unfortunate experience of maybe drinking something and laughing at the same time. So when you laugh, the vocal folds are open and something that was meant to go in that esophagus snuck in to your vocal folds and caused a problem. So we've all had that experience. So we know that they're close together. Likewise, if acid or pepsin is sneaking up through the top of the esophagus, it will cause problems, inflammation and irritation, primarily on that posterior, or in your image, upper part of the larynx. So here are some pictures. I don't have to go through a lot of them, but I just want you to appreciate what reflux can do. So in this first one, if you look at the top of the screen, that tissue is thicker, and the back of the vocal folds, you see that they're a bit red. Now look at the image right underneath that is C, and you'll see that that person has quite an overgrowth of that tissue. In that case, one of our physicians would probably want to biopsy that, but that can be a reflux event. And then on C's, letter C's vocal folds, they look somewhat red, and they've got some white sticky mucus on them. Picture B, that larynx just has a lot of inflammation, a lot of swelling. I'm sure the voice is not good for that patient. D is just some saliva, thickened secretions on the front part of what is the patient's left vocal fold. And then way over to the right, you see they look like marbles sitting in the larynx, and those are called granuloma. And chances are good that these are intubation granuloma. So if a patient has irritation and then they're having a surgery for something and they need to be intubated, right in that back region at the posterior part of the vocal folds is where the intubation tube sits. If you've got irritation or inflammation in the vocal folds and you have an intubation tube down there, after surgery, you can have a voice change, and it may be because you've developed granuloma like this. We've seen these quite often in our practice. One of the other things that we can offer patients that does tend to be covered by medical insurance is a restic pH probe study. I just put in 2 today, and you'll see in the image of the model here in the left, it goes in one nostril, and in the right, you see a little red dot there. There's a light on the end of the probe, and it will flash for about 2 hours, and that's just to help us get it in through the nose and to get it positioned correctly. But it sits up high, kind of behind the uvula, so it's not really too bothersome to patients. It's taped. The probe will be taped to the cheek. It goes over the ear, then it'll be taped on the neck. And the probe is plugged into a little transmitter. You see the blue transmitter where it's connected. So what this probe is doing is it's picking up vapors or aerosolized acid that comes up into the throat. And in this image, you'll see that the person also has a recording box that goes home with them. And the transmitter that's connected to her will communicate wirelessly with this recording box. And she will press different buttons that we've pre-programmed based on what her symptoms are. And every time she throat clears, she'll press that button. Or if she coughs, she presses a different button. If she gets regurgitation, and that's one of the symptoms we programmed, she'll press a button there. She also will press a button before and after eating and before and after reclining. And then when she comes back, I pull out an SD card from the recorder, put it in my computer with software, and we can look, and this waveform will come out with a lot of other information. But I just want you to see along the horizontal axis is time, and so it's on a 24-hour clock. So this was put in around 3 o'clock for her and taken out 3 o'clock the next day. And along the vertical axis is the pH level. Now, if her waveform, this is a very erratic waveform, if it stayed fairly compressed and stayed all in the top green area, then she would have normal, that would be a normal study. If it comes down to the light yellow, it's between 6 and 6.5, that's mild reflux. Lower in the dark yellow is moderate reflux, and then down into the pink area is severe reflux. And so we're able to look at events, we're able to look at when she eats, when she sleeps. We kick out all the meals in 5 minutes before and after. And we can see that this person really has a lot of reflux going on. This is very meaningful. I always show the patient this. They sit in the room when I'm analyzing it, and then we're able to look at the diary and see, you know, how long was the meal, and, you know, and that gives me some helpful information. If they ate a hamburger, a large fry, and a jumbo Coke in 3 minutes, and we're seeing a lot of deflections in the waveform, and then for an hour or 2 afterwards, they're still getting a lot of reflux events, that's really meaningful to me, for me to be able to sit with the patient and say, okay, well, look what happened when you did this. Look what happened when you laid down. And so this makes it more understandable for the patient, and I find often motivates them for treatment recommendations. This is a new study that is available now to us by the same people that provide the restic pH probes to us, and it's a saliva test. Europe has had these for a long time, but when I mentioned before that in laryngeal reflux, one of our concerns is not just acid coming up, but it's also this enzyme called pepsin. This actually evaluates the saliva for pepsin. And so what you do is you go online and you order this kit. This is not covered by insurance, and their price right now is about $150. But what you get in the kit are 3 little vials that have some reagent in it, and then it will tell you how to collect the saliva, and you'll collect it like over a day's period of time. And depending on the type of symptoms you have, let's say that you have most of your symptoms right after you eat, well, then it will probably direct you to spit into a vial after breakfast, 1 after lunch, and 1 after dinner. Then you mail this all back in a FedEx envelope, and within a month you get a result. And the result is either that you had pepsin in at least one of the vials, which means you have reflux. There are no false positives with this. If you had pepsin floating in the area, then this test is sensitive enough to show that. But if it didn't happen, if they didn't notice any pepsin in any of the vials, you may still have reflux. It could just be that you weren't having it on that particular day or in those particular time periods. So then in that case, we would want to go ahead. But I think this may be an attractive test for patients right now who, you know, some on the go, they don't want to have a probe in their nose, and they just want to be able to do this and mail it in and get a quick response. And if it is positive, then we can just start down the road for reflux. So this is one of the things that I go through with the patient, and in a few slides, I'll go through what all of these things are. But this is one of the things that I would do, and I did 3 times today with patients who I really think have reflux. I would go through dietary, postural, and then making alkaline water and alginate recommendations for them. And so that this is something that I do. And the handout that you will be getting, and I'm sorry you didn't get ahead of time. Kim and I've had a little email problem with my documents going through, but she has that available. And this is a handout that I give to patients, and then I will explain to them how to approach it. Now, when the patient goes over to the physician, they may put them on proton pump inhibitors, H2 blockers, or antacids to manage the reflux. Sometimes patients will try some of these that are over the counter on their own. A physician may also, I mentioned earlier, order a barium swallow or an esophagram. And if you look at this, they are X-ray studies. And when you swallow the barium, you look in that picture on the left and you're seeing a straight-on shot of the esophagus. And one of the reasons the physician may order that is if patients have like food sticking mid-chest level. And so we don't think it's really a laryngeal issue, but it might be an esophageal one. Or the patient says that food just, it takes a long time it seems like it takes a long time, and they feel very bloated. It's very difficult or painful for them to get food to pass, you know, into the stomach. So this allows the throat and the esophagus to be outlined, and they can get some stomach imaging too, and they can see if there are any masses, if there are any swellings. There are conditions like diverticulum that are pockets, and that gives them some idea as to what the esophagus looks like. Sometimes there's narrowing. You probably have heard of patients where the esophagus got narrow, and so it needed to be dilated to help them with swallowing. So we're going to go through the LPR treatment, and this will all be on the handout, but it's kind of good right now. You can just look at the screen and know that you'll get this information. I have 5 approaches to how I treat this, and I have varied it over my career just based on some new science information that comes out, and also patient response to treatment. So the first are behavioral changes, and it's going to seem like a lot, but when you think about all of the things that can cause either LPR or Gerd, now we're just going to reverse them. So rather than overeating, you eat smaller meals and you eat more slowly. Food does not move through the esophagus at the feed rate that we have. So, you know, all these 5-minute lunches that we have and things now are really not good for our digestion. The next one, if you're overweight, lose weight. Even 5 pounds can have a significant reduction in reflux symptoms for patients. And sometimes it's not just because they're losing belly fat, so they don't have so much pressure on the abdomen, but it may also be that they aren't eating some of the foods that cause the reflux to begin with. Next, this is a big one, avoid reclining or leaning forward within 3 hours of eating. And sleep on your left side. I'm going to show you some diagrams of some of these. Avoid wearing tight clothing. Avoid those foods which we know cause some problems, and quit smoking. So we're all kind of going through this. We were talking a little bit about this before we started tonight. The pandemic poundage, or the COVID-19 that people are putting on. And we're seeing a lot of people, I mean, you know, there's a lot of stress eating that's happening. Managing stress is another recommendation. But, you know, this is a very real problem. We are eating foods, we're out of our, this is a new normal for us to be home so much and to have such access to our kitchen. Now, looking at reclining, and I just turned this diagram on its side so you could see what happens. So on the right side of your screen, you're going to see the bulge of the stomach as it feeds into the esophagus. And this isn't as accurate shape, but I just want you to appreciate, if you lie down within 3 hours of eating, look what gravity can do. It can take everything to the left side of the screen, which means it can come up through the upper esophageal sphincter and spill into your throat, your mouth, your sinuses, your eustachian tube. The pepsin that I told you about has been found in sinuses. It's been found in eustachian tubes. It makes perfect sense. It's not going to just spill into the larynx. You're lying down. It can go all the way up into those areas. Leaning forward is another one. Think about where the stomach is in this picture. And look where the throat is. It is further down. And so things are going to come down just because of gravity. Now, this is a stomach, and I want to show you what happens and why it's more beneficial to sleep on your left side. So in the first picture, this is an upright picture of the stomach, and then you'll see the esophagus leading up from that. So when you're upright, this is good to stay upright after we eat. Things are digesting. They're going to be less likely to backflow. In the next picture, if you lay on your left side, so I just turn this onto the left side, the stomach, with the esophagus feeding into the stomach, the esophagus is still higher than the opening to the stomach. So you're less likely to have reflux. But if you look at the third picture, on the right side, you see that the esophagus is lower. So if you lay on your right side, it is very easy, and just gravity, just allowing things to come out of the stomach and up into the esophagus. So left side sleeping, people. The next thing I talk to individuals about is diet. And what I listed on this handout for patients and that you will see is the Mediterranean diet. Right now, it's the diet that my husband and I are recommending for reflux. There has been some science behind this that has shown that this primarily plant-based diet is a very healthy one for gut health, and that it can reduce reflux symptoms. You've probably heard about the Mediterranean diet. It really is the way that people used to eat in Greece in the 60s before they started eating the way that we do now. And it's advocated by many health systems. Mayo Clinic advocates it for cardiovascular health. It's Kaiser Permanente has recommended it for other medical conditions. So it is one that is strongly recommended that people follow, primarily because most diseases are due to inflammation, and this is an anti-inflammatory diet. It's good for arthritis. It's really beneficial. One of the things that we're finding out right now is that meat, including chicken, can really trigger the pepsin to be at high levels. And so when meat, animal-based products go down to the stomach, they can be more of a problem for contributing to inflammation. But in the case of what we're talking about tonight, it's reflux. The other thing that follows the Mediterranean diet is to really try to eat food as close to its natural state. So you want to avoid eating added sugar and processed foods. Most foods that are processed have these preservatives in them, and preservatives tend to be acidic. If we go to B, Dr. Jamie Kaufman is really the otolaryngologist that coined the phrase laryngopharyngeal reflux, and she's done a lot of research on this. She has 2 really good books. Maybe she has others since I started recommending both of them, but this one, the Dr. Kaufman's Acid Reflux Diet, and her first book, I find to be really helpful books. And I used to recommend this diet for patients. She now, in this book, also following kind of the vegan or vegetarian trend, and that's really what Mediterranean diet is. It's more vegan. But she also, has you eliminate gluten, because gluten products have changed so much over time, just the way farmers grow crops to try to get greater yield. We can have more problems in reaction to those, and our bodies haven't quite adapted to that. What she does and what other physicians have come up with in terms of low acid diets is to follow a restrictive diet for a few weeks to try to get all your symptoms to go away. So we think about the acidity of food on maybe a 10-point scale, and the closer you are to 10, the less acid there is. The number's closer to 1, the more acidic something is. And so she has measured, Dr. Kaufman has measured the pH level of all these foods, and she has a list of foods that should be safe for you to eat. She does say, if you, though, have some reaction to those, that might be one that for your physiology, you shouldn't be following. And so she tells you to get away from that. And then you can slowly bring foods back. So it's kind of like a limited elimination diet. And then you slowly bring things back. And I do have some patients that have been really motivated because they have not wanted to be on any medication, and they have followed this and have done very, very well. The third thing that someone could try is to avoid those foods that we know for a long time have contributed to reflux, and that's spicy, fried, caffeine, alcohol, excuse me, chocolate or peppermint. In addition, it is important to avoid any foods which cause problems for you that might be included in one of these plans. So a great one would be tomato sauce. There are a lot of people with reflux that really cannot eat tomato sauce. It will cause a lot of indigestion or heartburn for them. And you would be allowed to eat that on the Mediterranean diet. But what I tell people is, again, it's better to eat food in its natural state. And you might do very well with a few slices of tomato on a sandwich or a salad. But when you have tomato sauce, you take a lot of tomatoes, you cook them down, and that really concentrates the acid. And so you are getting a much more acidic product when you have it in the sauce or juice form. And the same would be for the fruit juices that we have. You might do fine with eating an orange, which is citric, and it's acidic. But if you have orange juice, which might be anywhere from 3 to 5 oranges, depending on how much of it you're drinking, you may have more of a problem. So try to eat the whole food. The next, and this is a really important one and something that we've been recommending probably about 4 years now for reflux, and this is at the recommendation of Dr. Kaufman's work, and that is to drink alkaline water. Alkaline water neutralizes that pepsin that may float up into the throat and contribute to acid reflux. So we want to neutralize it. And alkaline water you can get in the bottled water section of your grocery stores. Walmart, Costco have it. I'm going to show you what to look for on the bottle on the next slide. But you want to get alkaline water that's in a range of 8 to 10. You won't find anything over 10. You shouldn't. I don't think they make it that high. But it'll be 8 to 10. And I tell patients to buy whatever is cheapest and get a large quantity. If you can get the gallon jug, I know my Giant Eagle, down where they have the gallon jugs of spring water or distilled water, they'll have alkaline water down there as well. You can drink it as your primary beverage over the day. So for my patients that buy bottled water, I tell them just to switch over and buy alkaline water. It tastes like regular plain water. Or drink it after meals and at bedtime. Again, after meals, that pepsin level may be really high in the throat, and you want to neutralize it. So you drink it after meals and at bedtime. So if we look at this label, this is Trader Joe's alkaline water. Very often they'll say alkaline water with electrolytes. And you'll see in that dark box on top, that kind of little water droplet, it says pH 9.5 plus. This one is fine because it's between 8 and 10. Excuse me. Okay. You can also buy alkaline drops, and where you can make your own water alkaline. This variety also tells you that you can put it in any acidic beverages like coffee or pop. But if you do that, it may cause a taste difference. And if you do it just because the quantities are so different, you know, what one person's mug of coffee might be small relative to somebody else's, then you need a pH meter to actually measure, did you make it alkaline enough? But for patients, and I understand this, that don't want to contribute to the plastic pollution in our world, you know, they just really do not want to be buying that. What I have heard is that you need to use quite a few of these drops, and so it can be expensive to keep buying the bottle of these drops. And then, of course, you have to get this pH monitor. I have purchased this, and it's a refillable alkaline water that has a filter in it that should be able to make regular tap water alkaline, but it is a little bit cumbersome. You have to soak the filter, then you have to, just to get to activate all the little stones that are in that center filter that's coming down. And then you have to dump that water, and then you put it back in, you screw it into the lid, you fill it with water, you shake, 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 shake it. You have to let it sit for a period of time. And, you know, all that effort to quickly get your drink of water when you're watching your clock, but then you still have to either use pH papers to test it, or a pH meter to make sure that it's at the right temperature. But for people that are motivated, and again, want to use a reusable bottle, this could be an option for you. There's also an online recipe for how to make alkaline water. And so what's interesting about it, and I didn't list it here, is that, you know, one of the substances that will make it base or alkaline is baking soda. And so you're adding baking soda. I think a lot of people do not like the flavor of baking soda if you've ever had baking soda water. But baking soda adds a lot of sodium. And so if you're doing this multiple times a day, that can be an issue. The alkaline water does not have sodium in it. So you can think about this. If sodium isn't a problem for you, then you might want to make your own online. But again, you need a meter to test to make sure you made it alkaline enough. The next, and this is a game changer, are this whole category of alginates. And so this is number 4 of 5 recommendations that I make for patients. Alginates are derived usually from seaweed, and they are used to gel things together. So they are available in a variety of products. They might be in some skincare products to make them more gelatinous. How they're used for reflux is they are put in products where you will ingest it, and it coats the throat and the esophagus, so it can be very soothing. But the most important role that it provides is it provides either a gel or a foamy float raft at the top of your stomach after you eat, so it prevents regurgitation. They'll last anywhere from 45 minutes to 3 hours. And so if you take this after meals and at bedtime, you get a nice little way of preventing regurgitation up into the throat. You can still drink water. It'll move around the float. It's not a plug in the lower esophageal sphincter. It's actually a raft to prevent backflow. We've had great success with these. Now, unfortunately, the 2 that I can recommend that have a high enough dose of alginate are only available on Amazon. And I'll show you after that, but I just wanted to show you this little schematic of what happens. So antacids in that first picture work in the stomach to reduce or neutralize stomach acid, so you don't have so much acid that could possibly reflux up. Alginates in the second picture, you see that little white raft, that it has formed a little raft at the top of the stomach, and it will stay there while food is digesting, and then it just digests with the food and it leaves the stomach. In the third picture, there's a combo, and there is one product that I can recommend that you can get over the counter here. It's called Gaviscon Extra Strength, and that has a combination of an antacid with a small amount of alginate. It's not the amount that I like to see, but we've had patients that either have not wanted to order through Gaviscon or order through Amazon, or they've wanted to get something quickly and just give it a try, and we've seen good results with it. So we'll go through that. So the two preferred alginate options, and you can choose one, and if you try one and you don't really like it, then you can always try the next one when that one runs out. The first is called Reflux Gourmet, and it is an all-natural product. It was developed by 2 ear, nose, throat physicians in the United States and a chef. And it's available either through Amazon or their Reflux Gourmet website. And they've got a really good website. They answer a lot of questions. They show how this alginate works. And so I recommend that you go and look at that. And they have 2 delicious flavored products. Their first one was a chocolate mint, and it's just flavor that way. I know it sounds crazy, but almost all these antacid or medications where we're trying to drop acid reflux have mint in it, which we should avoid. And this one, chocolate as well, but they're flavorings. They're not one that's going to contribute to reflux. But anyway, it tastes like a peppermint patty that you might get at the dollar store. So it's not quite the peppermint patty, but you can tell when I tell patients, just think peppermint patty when you try it. And I will put some on a spoon so a patient can kind of see if they're going to like it at all, if that consistency is okay for them or the taste. But their newest one is a vanilla caramel, and it really is delicious. It tastes like a Werther's original caramel. And so as I'm trying to get people to stop eating within 3 hours of bedtime, I tell them, when you take this teaspoon of this at bedtime, that's going to be your dessert. Yay! And then the second one is Gaviscon Advance. And that is not an all-natural product. It has some other things in it. I've got a bottle here. Right here, it's got sodium alginate, which is their alginate, and potassium hydrogen carbonate in it. The Gaviscons may, if you take too much of them, they may cause diarrhea or constipation. So that's the only concern I have about that. I have not heard of any side effects with Reflux Gourmet. They haven't either in any of their studies, but they have said that if you have an issue, then of course you should stop using it. The Gaviscon Advance is available through Amazon UK or Canada. You just go to the regular Amazon and put in Gaviscon Advance, and it will come up. You kind of look for the bottle, and I'll show you what it looks like. And again, both of these, you could use either one of them. Gaviscon Advance comes in 2 flavors. One is anise, which tastes like black licorice, and some people love black licorice, so they really like that one. And peppermint is another flavor that they have. This is what the Reflux Gourmet looks like. All natural product. It's safe even for children and women that are pregnant. They also on their website will say that you can use it as an appetite suppressant. If you take it before a meal, it will kind of make you feel full faster. So they were recommending it that way. If it curled my hair and took care of wrinkles, I would really invest in it. But it is a wonderful product. I have to tell you, our patients really like it a lot. They did have a little bit of a supply issue, and this was even before COVID. And I thought, boy, my husband and I are recommending it a lot. I didn't think we shut them down, but they back that, and I have not heard of any supply issues right now from patients. This is what Gaviscon Advance looks like. It's very, very thick. I don't know if you can see me or if you just see my slides, but you have to really shake the bottle up, and it's a really thick substance. But again, it has a really good coating action. The 5th category of what can be recommended, and I only recommend the Gaviscon Extra Strength, but because the physicians are the ones that would be prescribing medications, and that would come under the proton pump inhibitors that you've heard about, the H2 blockers, and then the third are antacids. And the Gaviscon Extra Strength is not only an antacid, but it also has that low dose alginate. And we have had patients that have had really good luck with that without even trying the other two that I mentioned on the previous screen. So now I want to talk a little bit about when does an ear, nose, throat physician refer a patient to a gastroenterologist. And that is if the patient really seems to be having primary GERD symptoms. If it seems like it's an esophageal issue or really bad heartburn or pain with eating, the physician might order that esophagram, but they will send the patient to a gastroenterologist. We have not had good luck with gastroenterologists, GI doctors, of working up LPR. And it might just be, you know, where we're located, but they're very used to working with GERD, but not LPR. And sometimes and very early in my career, we thought, oh my gosh, this patient has laryngeal reflux. Let's send them to GI. And GI would say, oh, I don't really see much in the esophagus. And again, now we probably know why, and that is you don't need many incidences of this pepsin or acid coming up into the larynx before you get a lot of inflammation. But you need a lot of exposure in the esophagus to have GERD. So it's true, if they're going in with their scope and they're only looking at the esophagus and stomach, they might not see much when all the action is occurring up in the larynx. Another time that one of our physicians might refer to a GI is if we've ruled out laryngopharyngeal reflux on testing. Now, it could be that we're referring a patient to an allergist rather than a GI doctor. Maybe they're going to be referred to both, but if we've ruled it out, then we move on. Also, if a patient fails a medication trial for LPR. Now, for us, a lot of patients come in and they're like, I know it's not reflux because I tried Prilosec OTC for 2 weeks, and on the package, those proton pump inhibitors say, don't take longer than 2 weeks. Well, patients think you can't be on it longer than 2 weeks. What the package is telling you is you may have a serious problem. So you should really, if you aren't responding to this short-term reflux, you really need to see a physician. And our trials are more like 2 months for reflux management. Now, it doesn't mean it's going to take 2 months for you to have symptom relief, but it could be 2 months before we're going to try and get you off of medication. The next reason that an ENT would refer to a GI doctor is if that esophagram, that barium swallow study showed that there was an esophageal issue, then they would also refer. So my 3 big things, if you're only going to make 3 changes out of all the recommendations I had, these 3 are the 3 to start with. And the first is the behavioral change of not reclining or leaning back, reclining or leaning forward within 3 hours of eating. The second is to get on that alkaline water protocol of after meals and at bedtime, and then follow it with Alginate. And we've had success with people using Alginate just at bedtime and then after one other meal. Obviously, the more often you use it, the more likely, depending on which you choose, if you choose the Gaviscons, you may have some side effects. You might do better on 2 a day and working yourself up. But of course, if you had to order it through Amazon, you also will want it to last a little bit longer. And so if you can get to 2 times a day, that's great, but they're both approved for 4 times a day. These are my big tips on how to make some changes that might help you with managing reflux. Brush and floss your teeth immediately after dinner, or really after any meal, because when you've invested that much time and you get all this minty freshness in your mouth, nothing's going to taste good right away. And so you'll be less tempted to do all of this after evening snacking that we do. I think the most common thing that people tend to eat is a bowl of ice cream. And I know growing up, that's what my family always had as well. And so I'll tell patients, if you really need to have it as part of your meal. Don't have it later. But when you finish dinner, you need to tell yourself, kitchen closed, I'm going to brush my teeth, even brush your teeth before you clean up, dishes, if that's what your job is at home. And then do not eat until the next morning. Most of that eating, if you really think about what you do eat, is just snacking, it's reward, it's, yay, I got through another day type of food. The next thing I recommend is to kind of change your routine up. So if you get into these habits of eating, after dinner and going into the kitchen, maybe you go for a walk instead, Or maybe you put hand lotion on and gloves, or you do some knitting the way Ellen is doing, or do something to keep your hands busy, but break up the routine that you normally have so you can establish some new patterns. Next is to start small. Focus on changing one behavior each week. And my first one is to stop eating after dinner and have that three-hour window of time between when you finish eating and when you recline. That's my biggie. That's my suggestion. The next is when you get this handout, if you have reflux, I always tell patients, read through it, and then once a week, read through it again, because you will pick up new habits and tips each time you read through it. If you're having issues and we really can't tie it into something, and laryngeal reflux is really interesting, it might be hours after you ate something before you have symptoms. But go ahead and keep a food journal and symptom journal to look for symptom patterns. So sometimes patients will wake up and they'll say, I was really hoarse this morning. And I'll say, did you eat late last night? Yes, that's commonly what happened. And patients will say, no, I didn't eat before going to bed, but I woke up in the night and then I went down and I ate and then went back to bed. And I'm like, well, that's the same difference. So that's not something that you want to do. But if you keep a food journal and symptoms, we might be able to see that, oh, okay, you know, it was after you had lasagna or pizza or chili that the next day you had hoarseness or a lot of phlegminess in your throat. And last, remind yourself that changing your diet is cheaper than paying for healthcare, tests, and medications. Now, this is how reflux can impact your voice. And if you look at these images, you're going to see different levels of edema, which is swelling on the vocal folds, inflammation. The top right picture is a more normal larynx. If you look at the image right below it, you see those vocal folds are swollen. The one below that, you see the granuloma. The granuloma will not allow you to close your vocal folds well, and your voice will be breathy and hoarse. And if you've got swelling of the vocal folds, your pitch may be dropped, and you may have this husky voice. But all of these situations can result in some hoarseness. Now imagine if you have spasmodic dysphonia or tremor, and on top of that, you have reflux. So that's an interesting situation. And this is one thing I want you to know, that hoarseness is not a feature of spasmodic dysphonia or tremor. It is not. So hoarseness might be caused by reflux. It might be caused by a lesion. It could be due to aging or atrophy of the vocal folds. It could be due to muscle tension dysphonia. It's the rare patient that has spasmodic dysphonia or tremor and they don't have a secondary muscle tension dysphonia, because all these muscles want to come in and help stabilize the larynx and all of the muscles. And when that's an issue, you can end up with this secondary muscle tension dysphonia, and that can cause some hoarseness. Also allergies and changes that occur because of that, or medication. One of the things I didn't mention yet, but can be a cause of hoarseness, is just the drying effects of medication can cause thicker secretions, and that might make your voice sound hoarse. Next, just because you have spasmodic dysphonia or tremor does not protect you from developing another voice disorder. It doesn't say, okay, this is your SD card and you get a reflux card and you get nodules. You can have more than one thing. And third down there is we want healthy tissue, especially if you have spasmodic dysphonia or tremor or some other voice disorder. You don't also want to have reflux. You want the tissue to be healthy because it can improve your outcome for Botox treatments or any of the other things that you have as part of your treatment, whether, you know, it could be voice therapy as well. Healthy tissue is going to get you the best result from Botox. I get asked, is reflux just a mild inconvenience where I've got throat clearing, or maybe I have a morning sore throat, or is it something that's more serious? Yes and yes. It can range from anything from very mild inflammation that was because you were out late the night before and you were drinking a lot of alcohol and you had reflux overnight, but that's not a normal situation for you, and then you can recover pretty quickly from that, all the way to very serious condition associated with reflux chronic reflux, and that would be cancer of the larynx and esophagus. And so that's another thing that we really need to think about, and it's why it is serious and that we need to take care of it. This was a really interesting fact. My husband is, for those of you who don't know, is an ear, nose, throat physician. And we were watching online the Academy of Otolaryngology's talks, and we were spending a lot of time on the voice ones, especially reflux. And one of the authors quoted that $50 billion a year in the United States alone is spent only on LPR. And that includes testing, surgeries for other conditions, and medication trials. And LPR, again, is that silent reflux where, well, is it allergies? So you go off for allergy testing, which is very expensive. And maybe you do have allergies, so they start you on allergy treatment, but it doesn't really take care of this other condition of reflux. So now when you still have those symptoms, then, you know, you're still being evaluated and worked up for all of these other things. So it comes down really, I think, to this. Do you choose pharma medication to try and treat this, or do you choose the farm? And that really is getting back to thinking about how we're eating, what we're eating, and really caring and nurturing our bodies so that we can be healthy. Almost every medication that a patient goes on has side effects that might necessitate being on another medication. We're really trying to get away from prescribing the proton pump inhibitors. We know that the Prilosec and Nexiums and Protonix and Pantoprazole have been prescribed for years to patients. And sometimes patients will try to get off of them themselves, and they'll have a rebound effect where, because they've stopped it and your body is now used to having this acid suppressed, you get this big release of acid. And so we try to get people to wean off of those medications or to be on them, you know, as a last resort, and on the lowest doses that they can be on. So I love this. And if you watch have seen any of the Netflix documentaries, you know, Forks Over Knives, or any of them, you know, the keto diet, all of them, you know, many will quote the "let food be thy medicine and medicine be thy food," which is Hippocrates. So this is our Christmas card this year, and this is my last little plug. So please mask up so we can dress down. I never had a mask on my face before March, and now I can't see a patient without a mask and goggles on. And then if I'm evaluating their larynx, and these are people that have been tested for COVID prior to my seeing them, I still have to gear up. So that's my husband and I.